Hello, this is Debu Tripathy. I'm reporting to you from the 32nd Annual Miami Breast Cancer Conference, and we have assembled a very large group of breast cancer specialists representing the surgical field, the medical field, radiation oncology, genetics. We also have nurses, nurse practitioners, pharmacists, a very wide array of experts that are focusing in breast cancer. And this is a very interactive meeting covering the whole breadth from screening to prevention to treatment. And I want to focus on a couple of areas that have been covered over the course of the 2 days. In the first one, I want to focus on surgery and local therapy, which includes radiation therapy. And just by way of background, the successful treatment of early stage breast cancer includes several different modalities. Surgery is a very important part, of course, to remove the tumor. And many times we also use medical therapy, such as hormone therapy and chemotherapy, to lower the risk of the cancer coming back. And also radiation therapy can be helpful in certain situations to lower the risk of not only recurrence in the local area that receives radiation, usually around the breast or chest wall, but also to prevent distant metastases to places like the lung, bone, and liver. So the areas that were discussed are new, emerging, and in some cases controversial. One of them deals with how we use radiation therapy. Now, after patients have a lumpectomy, radiation therapy is usually recommended because it lowers the risk of the cancer coming back within the breast. There are several ways radiation therapy can be given. It traditionally has been given over a 6-week period, which is rather inconvenient. And there is a new approach that has been tested over the last 10 years or so called hypofractionated radiation, where a larger amount of radiation is given every day, but it's given over a shorter period of time, typically around 3 or 3.5 weeks. Studies to compare these two have been done primarily in England and in Canada and have shown equivalent results and no more in the way of side effects. So Dr. Buchholz today covered the criteria that we use for selecting the right patient for hypofractionated radiation therapy. And the selection criteria vary across countries. In some cases, we're not precisely sure of the ideal candidate, but we generally think that it's going to be someone with a smaller tumor, someone that may not have lymph nodes involved, and patients that have tumors that may not be as biologically aggressive based on the hormone receptor status. So now it's important for all oncologists to evaluate this, and for those of you that are having radiation, to check with your radiation oncologist to see if you may be a candidate for this. Another area of radiation is for the higher risk cancers, and should we be extending the field of radiation to include what are called the regional lymph nodes. These are lymph nodes around the axilla, under the arm, in the supraclavicular area, over the collarbone, and then in the internal mammary area, which is around the chest bone, the sternum. So these forms of radiation therapy have been tested in randomized trials that show that for patients with larger tumors or with positive nodes, that there is a reduction not only in local recurrence but distant recurrence as well. This is still an evolving field, and the criteria by which such patients are chosen vary again from center to center and are somewhat controversial, but the bottom line is that for patients with more aggressive cancers and with positive nodes, this is also a specific issue that needs to be discussed with the patient and with the radiation oncologist. And then the final area that was covered in the last day or two is a new guideline that came out looking at surgical margins. When a patient has breast surgery, whether it's a lumpectomy or a mastectomy, it's very important for the pathologist to very carefully review the size of the tumor, as well as the location of the tumor, whether or not the lymph nodes are involved, and then what we call the margin status. This is, does tumor go all the way up to the edge of what was removed? And that gives us a sense as whether there may be any tumor left behind. So traditionally, we have aimed to get negative margins, but not only negative margins, but to have a space of anywhere from 3 to 4 to 5 millimeters of free regular tissue, non-tumor tissue, that separates the tumor from where the surgical incision is made. So the big question has been, how close should the margin be for us to recommend whether the surgeon should go back in and take more tissue or do what's called a re-resection, or if a re-resection is impossible, whether we might need to add more radiation or other treatments. Recently, guidelines were changed and stated that an acceptable margin is anything that's negative, and even if it's negative by only a fraction of a millimeter, or what they say, no ink on tumor, and that means that the ink that is often used to color the edge of the specimen, this helps the pathologist recognize where the tumor ends and where the tissue was cut, that if there's no ink on the margin, in other words, even if it's just a millimeter or a fraction of a millimeter, that's still considered negative. So most surgeons now feel comfortable that they don't need to do any more surgery. But from the side of the radiation oncologist, they're not quite sure whether or not they should give what's called a boost or extra radiation to that area. And the final thing I should say about this whole area of negative margins is that we have to make sure that we don't only go by the rule of no ink on tumor, as they call it, but we also factor in other biological characteristics of the tumor. For example, if the tumor is very high grade, if it's estrogen receptor negative, which is higher risk as well, then we may actually want to get a little bit more than a millimeter of margin. So those are the main updates that apply to very common treatments that we are using in breast cancer that were discussed at the Miami Breast Cancer Conference.